Hi, everybody. Thank you very much for inviting me to give these lectures and presentations and Viber sessions. So we'll get started on the first lecture. The first lecture is on pediatric spine deformity. So the contents of this lecture will cover adolescent idiopathic scoliosis, infantile scoliosis, congenital scoliosis, and syndromic scoliosis. The definition of scoliosis essentially is a three-dimensional deformity of the spine, defined as a lateral curvature of the spine in the coronal plane of more than 10 degrees. When you're defining and categorizing scoliosis, there's essentially three major types. You can divide it into congenital, syndromic, and idiopathic. In regards to idiopathic scoliosis, it can be further subdivided based on age. So infantile scoliosis is between 0 to 3 years, juvenile is between 3 and 10, and adolescent is greater than 10. Another way of classifying it is either early onset or late onset. So early onset is below 10 years old, and late onset is beyond 10 years. In regards to adolescent idiopathic scoliosis, the etiology is very diverse. It's considered to be a multifactorial disease with genetic predisposing factors. The prevalence is 2 to 3%, and overall there's a female preponderance. In regards to its natural history, this was studied in a prospective case series of about 133 patients, which they followed up for an average of 40 years. And they found that thoracic curves greater than 50 degrees tended to progress at approximately 1 degree per year, as compared to thoracolumbar curves, which progressed at 0.5 degrees, and lumbar curves, which progressed at 0.24. And they found that thoracic curves below 30 degrees did not progress. When you approach and take a history from a patient with adolescent idiopathic scoliosis, you have to ask them what the presenting complaint is. Patients often present with unlevel shoulders, waistline asymmetry. They may complain that one hip is sticking out, or a rib prominence. This is most usually identified by the patient themselves or a family member or a general practitioner. Sometimes the patients will present with back pain. During your history, it's important to ask about what their presenting complaint is, including back pain, and whether they have any neurological symptoms, any pain or paresthesia in upper and lower limbs, and also concerns regarding cosmesis. You also want to get a good pain history as well if they're complaining of pain. Do they have constant pain? Do they have night pain, radicular pain? This is to look for any underlying pathologies such as to exclude tumors and other red flags. It's also very important to get a good birth history. So any difficulties during labor may be associated with cerebral palsy and potentially other non-idiopathic forms of scoliosis. You also want to ask about developmental milestones. When were they able to sit up? When will they able to walk? Have they achieved their developmental milestones throughout development? Again, if they have developmental delay, this can suggest a non-idiopathic form of scoliosis. Also, you want to ask questions to assess the physiological maturity. So you may want to inquire about the growth spurt. And if it's a female, you want to ask about the menarchal status, because the onset of menarche suggests that growth starts to slow down from that point for about 2 years from the onset of menarche. With regards to the examination, clearly you want, starting off with inspection, to do an adequate inspection, you want adequate exposure. So for boys, you want just to be in their underwear or shorts, and if it was a girl, it would be a bra and their underwear. So first of all, you want to inspect them. You want to look at their shoulder heights to see if there's any asymmetry of their shoulders. You want to look at their pelvis, and again, asymmetry of the pelvis. You then also want to evaluate their gait as well. So you want to look at their gait and their posture, When you get them to walk, you're especially looking for any short leg gait and to evaluate for leg length discrepancy. You want to see if they're listing to one side or the other. And then during the inspection process, you're looking for specific signs that is this a non-idiopathic type of scoliosis. So you're looking for cafe au lait spots, which could indicate neurofibromatosis. You're looking for axillary freckling, again, indicating neurofibromatosis or neurofibromas. You also look at the back to look for any hairy patches or skin dimpling, which could suggest spinal dystrophism, such as spina bifida. In the patient's upright posture, you want to, again, evaluate them from the front, the back, and the sides. You want to evaluate the heights of the iliac crests, their shoulders. You want to also then see if they do actually, can you actually see a spinal curvature? If you see a spinal curvature, is it in the thoracic spine? Is it the lumbar spine? And you basically describe it according to the convexity of the curve. So if you see a thoracic curve, which is convex to the right-hand side, then it becomes a right-sided curve. And as you can see in this photo, this patient is having their coronal alignment assessed. So essentially, they're dropping a line or a tape or a thread from the C7 spinous process, and they're looking at how far it's deviated from the gluteal cleft or the midline of the sacrum. And then you're looking for, ideally, it should just go through the midline. If it's deviated more to the right side, then there's coronal imbalance to the right. And if it's to the left side, there's a coronal imbalance to the left. You also want to evaluate for leg length discrepancy. So essentially, if you feel that on examination when they're standing up, there's asymmetry in their heights of the iliac crests, you may put some wooden blocks to get the pelvic level if there's a leg length discrepancy. And at that point, you see whether the scoliosis is still present or not. Because essentially, leg length discrepancy can cause a postural scoliosis. So you're seeing, is it a postural scoliosis or is it a structural scoliosis? Another way to eliminate leg length discrepancy is to get the patient to sit down on a chair, and that eliminates a leg length discrepancy. And then you're seeing, is the scoliosis still there or not? Subsequently, it's very important to perform the Addams forward bend test. Here, with the patient standing up and the knees extended, you get the patient to bend forward with the hands together. And here you're looking for the rib prominence, which you can see on this photograph on the right-hand side. And again, you're looking whether the scoliosis is still present or not. Because if it's a postural scoliosis on the Addams forward bend test, it will disappear, whereas a structural one will remain. And then subsequently, last of all, on examination, it's important to do a thorough neurological examination. And during the neurological examination, it's also very important to do the abdominal reflexes. So when doing the abdominal reflexes, essentially you're dividing the abdomen into 4 quadrants around the umbilicus. And you use the end of a patellar tendon hammer and you stroke each of the 4 quadrants. And what you would expect is the umbilicus to move towards the point of stimulation with your patellar tendon hammer. And this should be symmetrical in all 4 quadrants. When there is asymmetry, this is suggestive of spinal dystrophism or an underlying disorder, and this would be an indication to get an MRI scan. Regards to imaging, you want to get full-length PAA and lateral view x-rays of the whole spine, and lateral bending views would be used for surgical planning to evaluate for the flexibility of the curve, which will help you guide fixation levels. Regards to curve patterns, the majority of the curves are right thoracic. And again, there's a Lenke classification, which you do not need to know for the exams, but essentially will define the different patterns of curves that are seen. But essentially, you can get thoracic curves, lumbar curves, combination of those curves. And sometimes, quite often when you have a structural curve, which is a main curve, then you get a compensatory curve to try to balance it out as well. When you see a left thoracic curve, that's of concern because that is unusual and it's usually associated with underlying spinal dystrophism. So when I'm talking about spinal dystrophism, I'm talking about conditions within the spine, such as diastometromyelia, the most common form of spinal dystrophism, arnold-Chiari malformation, syringomyelia, which means the presence of a syrinx, Arnold-Chiari malformations, which can be associated with herniation of the brain contents through the foramen magnum, and also intraspinal lipoma or cord tethering. So when you see a left-sided thoracic curve, you'd consider an MRI scan. When you get your X-rays up to measure the size of the curve, you need to know what the end vertebrae are. You need to decide on the end vertebrae. So the end vertebrae are the vertebral bodies in the proximal and distal aspect of the curves, which are most tilted towards the concavity of the curve. So what you then do is decide on your superior end vertebra, inferior end vertebra. You draw a line along the superior end plate of the superior end vertebra. You draw a line along the inferior end plate of the inferior end vertebra. And then you draw perpendicular lines to those two lines. And then the cross-section of that angle is formed by the Cobb angle. And the Cobb angle is important to measure in every single patient with scoliosis, because this will help you plan treatment and to determine whether the curve is progressing. And it's usually important to have the same end vertebra in your mind and documentation to subsequently measure progression. Risk factors for progression. So age is important. So the younger you are, the greater potential you have for growth and curve progression. Females are more likely to progress. Menarche is important to know because progression is least after menarche. It slows down for 2 years afterwards. And other measurements, which I'll describe in the subsequent slide, is RISA sign, which can help you determine progression, which is a measurement of the progression of the iliac apophysis. Curve patterns can also indicate progression. Double curves progress more frequently than single curves, and also clearly curve magnitude. So assessing curve progression, there's different ways of assessing curve progression. Again, there is, there's different staging methods. So there's a Tanner staging method, which looks at secondary sexual characteristics. It's not as reliable as the more skeletal methods. So other methods are using hand X-rays, such as the Sanders staging system, which is staged from 1 to 8. And there's also one by DiMeglio, which looks as apophysis around the elbow. The one that's more commonly used is the RISA staging method, which evaluates the progression of the iliac apophysis from the anterior superior iliac spine to the posterior iliac spine, and terminates with fusion with the ilium as well. It has 6 grades from 0 to 6, with 0 and 1 at the early stages where there's lots of growth, and growth tapers off at 4 and completes at 5 when the iliac apophysis completely fuses with the spine. So when do you consider brace treatment? So brace treatment is generally considered for curves greater than 25 degrees and in the immature spine. So when we're talking about RISA 0 and 1 and above 25 degrees, that would be a candidate for bracing. You could consider bracing patients with curves less than 25 degrees if they show evidence of progression. So progression means the curve increases by greater than 5 degrees at 2 consecutive follow-up appointments, which are either 4 or 6 months apart from each other. You can also consider it for higher curves, 30, 40 degrees, if they still have growth left. But there's no point in doing, there's little benefit from bracing patients 30, 40 degrees who are RISA 4, RISA 5, who have pretty much finished growth. So the contraindications for bracings are curves over 45 degrees, because these patients should be considered more for surgery, and also children who have completed growth, because bracing, again, will not be effective. So when do you consider surgery? So surgery, again, is considered. Overall, about 10% of patients with adolescent idiopathic scoliosis will progress to surgery. So surgery is generally indicated to treat a significant clinical deformity So significant clinical deformity would be a curvature of 45 to 50 degrees. And also to correct a scoliotic deformity that is likely to progress. So say an immature patient just about to enter the adolescent growth spurt has a 30-degree curve already. And and you know that if you leave this patient or brace them, it's still not going to be enough to control the curve. So such a patient with a smaller curve will still require surgery, as you know that it's going to progress quite rapidly during the growth spurt. So evidence of curve progression would be, again, another indication for surgery. In terms of surgical treatment options, there's different ways of approaching it. The most common surgical approach would be a posterior fusion of the spine. And essentially the aim of the surgical procedure would be to fuse as little motion segments as possible, fuse across the curve, try to get a balanced spine, and to have high fusion rates as well. So generally it's done posteriorly, but if you've got a very solitary curve, such as a solitary lumbar curve or thoracic curve, you can use a purely anterior approach, which can be seen on the radiograph on the left-hand side. Or if you've got a very stiff curve, where on the bending views where you're still got a curve about 60 degrees, you may need to do an anterior release, where you go through the anteriorly and you take out all the disc spaces and insert bone graft and cages, and then go through the back and fix it. That's for very stiff curves. Moving on to another category, which is infantile scoliosis. So infantile scoliosis is pretty much the opposite. Here you see it more commonly in boys, whereas in adolescent idiopathic scoliosis is mainly in girls. And this is categorized between birth and 3 years. There's an increased association with hip dysplasia, mental retardation, congenital heart disease. And many of these curves will actually resolve spontaneously. But those that progress have to be taken seriously, because this is the important period where your lung is going to be developed. Lung development goes up to about the age of 8. So any severe curve at this level can have a significantly detrimental effect on your lung function. And the rib vertebral angle is very important to know. This was first described by Min Mehta, who was working at the Royal National Orthopaedic Hospital in Stanmore, originally from Calcutta. And she basically, her interest was looking at the early detection of progressive curves. And the aim of her study was to define a radiological method for differentiating between resolving and progressive curves at this early age in infantile scoliosis, and also to examine the influence of the early growth spurt on progressive curves. So she described this rib vertebral angle difference to help distinguish between progressive and resolving curves in infantile scoliosis. So to measure the rib vertebral angle difference, you need to define the apical vertebra, which is the vertebra in the center of the curve. Then you draw a perpendicular line down the center of your vertebral body, which is known as the vertebral line. And then on either side, you draw a line down through the rib head and neck to the point it intersects with that vertebral line, and measure that angle on both sides. And the difference between these, the angle on the concavity and the convexity of the curve is called the rib vertebral angle difference. If this value is below 20 degrees, she found that the curves did not progress. Whereas if the angle was greater than 20 degrees, they would progress, and hence such patients would need treatment. She also describes the phase of the rib head. So in the phase of the rib head, you again looking on the convexity of the curve to see if that rib head overlaps with the vertebral body. She found that if it didn't overlap with the vertebral body, described as phase 1, such curves did not progress. Whereas if a curve was in phase 2, she found phase 2, where there's overlap of the convex rib head with the vertebral body, these curves definitely did progress. So a progressive curve, a shift from phase 1 to phase 2, suggests that it's a progressive curve. So in phase 1, if a curve is if the rib head is in phase 1, it could either progress or not progress. So in these patients, you measure the RVAD to see if it's above or below 20 degrees. If it's entered phase 2, that means it's definitely going to progress, and there's not even any point of measuring RVAD at that point, because it is by definition a progressive curve. In terms of management of such patients, ideally you want to try avoiding fusing these patients, because they still have lung growth available, they have spine growth available. You've also got to remember that you don't want to ideally fuse the spine until the age of 10. Because that's when, by the age of 10, 80% of your vertebral height has been achieved. So you're more comfortable fusing the spine at that point. And clearly, you want to achieve a lung growth until the age of 8. So so a lot of these children are treated with casting on a special table, which is either known as a RISA table or a META table. And these casts are changed at every 6 to 12 weeks. And generally, these infantile scoliosis cases, you'll start casting these curves when they reach about 60 degrees. And the aim is then to reduce the size of the curves to about 50. And then at that point, you might start bracing them. And if they then still continue to progress, despite casting and bracing, you may look at non-fusion surgical methods. So these are the growing rod techniques, which allow control of the curve whilst allowing the spine to grow and the lungs to develop. So there's different types of growth-friendly systems, such as growing rods. So you can have single rods, dual rods, or on this photograph, you can see magnetic growth rods, which has a magnet which you can control outside the patient to achieve sequential distraction. There's other techniques such as staples, tethers, and other techniques such as Luque and Schiller techniques, but they all have the same concept of controlling the curve whilst allowing the spine to grow and the lungs to develop. Moving on to congenital scoliosis. So congenital scoliosis is lateral curvature of the spine secondary to a vertebral anomaly that causes an imbalance in longitudinal growth of the spine. So embryologically, the 5th to 6th week of is when the spine develops, and this is when the defect occurs. And the etiology is multifactorial, with the approximate prevalence of 1 in 1,000 births. And this typically occurs in the thoracic spine. 60% are associated with congenital abnormalities. And you should know the vectoral mnemonic. V stands for vertebral anomalies, A stands for anorectal anomalies, C stands for cardiac, T for tracheal abnormalities, E for esophageal, R for renal, and L for limb. So neural axis abnormalities are seen quite often on an MRI scan. So these patients should have MRI scans. Also watch out for the lower limb abnormalities, which can be diverse from asymmetric calves to cavus feet, to club feet to vertical tali. Also, a proportion of them will have congenital problems and genitourinary problems also. In terms of classification of these deformities, so you can divide them into failure of formation, which can be incomplete. So example of incomplete failure of formation is a wedge vertebra, which has this wedge shape, but the wedge vertebra will still have both its pedicles intact. And you can also have a complete failure of formation, which means the formation of a hemivertebra as opposed to a wedge vertebra. So in a hemivertebra, there'll be an absence of one pedicle in one part and a segment of the vertebral body also. Hemivertebra are classified as either fully segmented, where the hemivertebra has an intact disc above and below. Partially segmented means the hemivertebra is either fused to the vertebral body above and below, so it only has one disc space. And unsegmented means that it's fused to the vertebral body and above and below. So there's no disc spaces adjacent to the hemivertebra. So this diagram, again, on the left-hand side is a fully segmented hemivertebra. The middle one is partially segmented, and the one on the right is unsegmented. And the second classification of congenital abnormalities would be failure of segmentation. So this can either be a unilateral failure of segmentation, which results in the formation of a bar, which acts as a unilateral growth tether, or you can have a bilateral, which results in a block vertebra. In terms of progression, 25% of these hemivertebrae show no progression, 50% progress rapidly, and 25% progress slowly. Progression more likely up to 5 years of age and during puberty. And the combination to watch out for is the mixed type, where you've got a unilateral bar on one side with a contralateral fully segmented hemivertebra on the other side, which has a worse prognosis and is most likely to progress. In terms of surgical treatment, generally you would, again, prognosticate, depends on the configuration. So if it's progressive, you would more likely to consider surgery, or if it's greater than 40 degrees, you're more likely to consider surgery. The aim of the surgical options is to obtain a balanced spine whilst maintaining flexibility. There's different ways of approaching it. Initially, you may consider non-surgical treatment methods such as bracing. In spite of this, if it's progressive, you may consider, again, going rod techniques. If it still continues to progress with deformities, you can consider in situ fusion. Or if there's a significant deformity already with an imbalanced spine, you could consider a hemivertebral excision, which could involve, you can do completely posteriorly, or it can involve an anterior and posterior approach. Moving on to syndromic scoliosis, this includes a large number of conditions that could cause it. So you divide it into neuromuscular. Neuromuscular scoliosis can be divided into neuropathic and myopathic, and each of these have a number of conditions under the categories. And I'll go over some of them because they're quite relevant to the exams. You might get them as clinical patients or in Viva stations or even MCQs. So regards to syndromic scoliosis, they generally tend to have long C-shaped curves with rapid progression is more common, can lead to thoracic insufficiency syndrome. Pelvic obliquity is more common, associated with hip contractures and dislocation. The aims of treatment is to maintain cardiorespiratory function, promote mobility and ambulation, and preserve sitting balance. An example would be cerebral palsy is a condition in this category. It's the most common cause of neuromuscular scoliosis. Then these curves can continue past maturity. Bracing effective only in the ambulatory patients. Scoliosis is more common in the GM FCS grades 4 and 5. So it's important to know GM FCS, which is graded from 1 to 5. So 1 is when they're mobile and 5 is when they're pretty much completely dependent in a wheelchair. So once they become more immobile, they're more likely to have the scoliosis. When you're fixing these curves, generally you need to fix them down to the pelvis to address the pelvic obliquity. Other conditions, Duchenne's muscular dystrophy. This is an X-linked recessive progressive myopathy involving skeletal and cardiac muscle, and involves a gene that encodes dystrophin, which is a protein that stabilizes muscle cell membranes, and presence usually in the preschool male. The child usually presents with falls, clumsiness, toe walking. Other clinical signs would be pseudohypertrophy of the calves. One blood test that you would ask for is CPK, which would be elevated significantly. Another common sign is a Gower's sign, where the child essentially uses his hands to push off with their legs extended to try to stand up because of the muscle weakness. And steroids have significantly improved the prognosis. Spinal muscular atrophy is a genetic condition. There's four different types of SMA. Type 1 is lethal as an infant. Type 2, where the infant can't walk. Type 3 is the child is normal up till about 18 months and they regress. And type 4 occurs as an adult. It's a progressive loss of alpha motor neurons in the anterior horn of the spinal cord. And essentially, its proximal weakness moves through distally throughout the body. And surgery should be considered early in these patients. Friedreich's ataxia, it's a spinocerebellar degenerative disease, autosomal recessive. And this onset usually occurs a bit later on, usually in the 20s, as opposed to the other forms of scoliosis. And these patients can present with ataxia, areflexia, and also other associated anomalies such as cave of varus feet. And death is usually from cardiomyopathy in these patients. Rett syndrome is a neurodevelopmental disorder with X-linked dominant inheritance. And these patients also have normal development up to about 6 to 18 months, and they start regressing with mental retardation, spasticity, and significant behavioral anomalies as well, and with 50% unable to walk by 10 years. It's also important to know about myelomeningocele, spectrum of disorders. So spina bifida occulta, where there's failure or formation of the posterior bony elements of the spine, which fail to fuse. But these patients have no neurological deficits. Meningocele is when there is the dura and the tissue overlying the spinal cord pouch out through the bony defect, but the spinal cord remains intact, so there's little neurological impairment. Myelomeningocele is a more severe form, where actually the neural elements pouch out and may even be completely exposed. And this can be associated with significant neurological deficits. Another condition associated with scoliosis is neurofibromatosis, which is autosomal dominant. And again, on examination, you might find cafe au lait spots. And to diagnose neurofibromatosis, you need 6 cafe au lait spots greater than 5 millimeters. And you also need 2 neurofibromas or 1 plexiform neurofibroma, axillary freckling. Radiographs may show vertebral scalloping, penciling of ribs, enlarged foramina. There's 2 types of curves. There's the usual curve, non-dystrophic curve of neurofibromatosis, which is just like the curves you see with adolescent idiopathic scoliosis, and you manage it just like that. And you also get the dystrophic curves, which are more worrying, which are typically thoracic, associated with kyphosis, and have a sharp angulation. And these tend to progress more rapidly and more frequently require surgical treatment. And when you treat these curves, they also have a higher association with pseudoarthrosis. So quite often you may need to go through the front and through the back to fuse these curves. Thank you. So that's the first lecture. So I'll now move on to the second lecture. So this will be, so this is covering lumbar spondylolysis and spondylolisthesis. So spondylolysis is a defect of the pars interarticularis. So the pars interarticularis is the segment of the bone that connects the superior articular process to the inferior articular process of that vertebra. And it's one of the most commonest causes of back pain in the adolescent. And it's most commonly seen in adolescents who are very active, especially in hyperextension sports such as gymnasts or other athletes involved in lots of extension activities. Incidence is between 4.4 and 6%, and the L5 vertebral body is the most commonly affected. There's different types of spondylolysis. So isthmic type is the most common and is attributed to a stress fracture of the pars from repeated hyperextension. The dysplastic type is less common and is caused by congenital deficiency of the inferior facets of L5 and or the superior facets of S1 and elongation of the pars. In terms of diagnosing, a plain lateral X-ray is difficult for diagnosis. So an oblique X-ray creates what's called the Scotty dog view. And the pars intercalaris is seen as a line across the neck of the dog or the collar. So you can see on that radiograph, there's a lytic area across the neck of that dog, and that is the pars defect. MRIs can also be used, but they're not as accurate as a CT in terms of diagnosing a pars defect. And a SPECT CT is quite useful in managing a pars defect, as it can see as increased uptake suggests that this is an active defect which has a potential to heal, whereas one with little uptake suggests that it is a cold lesion which may not heal. And all of this will help you with planning your management of a patient with a pars defect. Generally, when you see a patient with back pain and diagnosis of pars defect, you manage them with analgesia. If they're quite active, you would advise a trial of activity restriction, refer them to see a physiotherapist, and quite often I would brace them as well. So a trial of bracing for about 3 months. And this actually has quite a high success rate. If despite conservative measures, they continue to have pain, which causes disability for them, again, I would get further imaging, CT scan or a SPECT CT scan. And if it does, if they still have ongoing pain, I would then also get an MRI scan also, because an MRI scan is important for me to look at the disc space. So if it's an L5 pars defect, I want to look at the disc space to see if there's any degeneration. If there's no disc degeneration and there's no significant slippage of one vertebral body on the other, I would consider a direct pars repair. Whereas if there's evidence of disc degeneration or a listhesis of greater than grade 1, I would consider a lumbar fusion. So this is an example of a direct repair. So this patient has a L4 pars defect, and I got an MRI prior to surgery, and it showed that there was no evidence of disc degeneration at L4, L5. And also this patient had no anterolisthesis at L4, 5. So this was a candidate for a direct pars repair. Moving on to spondylolisthesis. So regards to spondylolisthesis, you've got to know the classification. This is the Wiltse and Newman classification, which divides spondylolisthesis into type 1, which is dysplastic type, type 2, isthmic type, type 3 is degenerative. So isthmic is when you've got pars defect and it causes the subluxation. Dysplastic is when you've got abnormalities such as an elongated pars, which then leads to the listhesis. Type 3 is degenerative, which you see in the more older population, where you've got wear and tear of the facet joints and of the capsule that causes the sliding of across the facet joints and the spondylolisthesis. Traumatic, associated with fractures, so you can get traumatic pars fractures or pedicle fractures, which then cause the listhesis. And pathologic, which could essentially be associated with infection or tumors. The Mayerding classification will classify you in terms of the severity of the slippage. So grade 1 is up to so you break up the superior end plate of the, say at L5S1 of the vertebral body below into 4 quadrants. So grade 1 is a slippage of approximately 25%. Grade 2 is up to 50%. Grade 3 is up to 75%. Grade 4 is when it's just hinging at the edge. And grade 5 is spondyloptosis, when it completely comes off the end plate below. So when to consider surgery? So these patients will quite often present with back pain, but also with leg pain symptoms as well. So if you've got say an L5S1 slip, as the L5 vertebral body slips forward, it'll compress the L5 foramen, L5 nerves coming out of the L5 foramen as the L5 vertebral body slips over S1. And then they will get bilateral L5 radiculopathy. So the patients with, say, a lytic spondylolisthesis, the younger population, they are more likely to get the foraminal stenosis as one vertebral body slips over the other. The degenerative patients, the older patients, they are more likely to have central stenosis because there's more of a degenerative process over a long time. So they'll have the flaval hypertrophy and the more central stenosis. So they'll present more with symptoms of neurogenic claudication rather than foraminal radiculopathy. They may present with neurological deficits. They could present with foot drops as the L5 nerve root gets compressed from an L5S1 spondylolisthesis. Or they may get symptoms from sagittal imbalance, so increased back pain, fatigue, and so you consider surgery when you try all non-operative measures with analgesia, physiotherapy, and despite all of that, they still have symptoms. You can consider surgery, or you consider surgery if they have acute neurological deficits. Another indication for surgery would be slip progression. So another question you may get asked during your examination is, when would you fix these listhesis in situ as they are, and when would you reduce them? So you don't necessarily need to know this classification, but this is a more up-to-date classification of spondylolisthesis, and it helps you guide which ones to fix in situ and which ones to reduce. So in this classification, essentially, if you've got a spondylolisthesis, which is low grade, generally, which is either grade 1 or grade 2, you can fix them in situ. It's not necessary to reduce them. When you have high-grade spondylolisthesis, you have to determine whether this is a balanced spine and pelvis or not. And if it's a balanced spine and pelvis, you could do an in situ fusion. If there is compensation, if the pelvis is compensating for the imbalanced spine with the retroverted pelvis, then you should more consider a partial reduction in fusion. A complete reduction is a more riskier option, simply because the nerve is used to being in a certain position, and if you over-reduce it, you could injure that nerve, and that could result in permanent neurological injury and foot drops. So when we're talking, an important part about deciding whether to reduce or to non-reduce is whether it's a low-grade or a high-grade slip. And if it's a high-grade slip, you have to decide whether it is if the patient is balanced or not balanced. And when we're talking about balanced or non-balanced, we're asking, is the pelvis and is the body compensating for an unbalanced spine? So when we're talking about sagittal balance, there's certain terms that we should know, such as the pelvic incidence. So pelvic incidence is an angle that's measured. So you draw a line from the center of the femoral head to the midpoint of the sacrum, another line from the midpoint of the sacrum perpendicular to the sacrum. And that angle between these two lines is the pelvic incidence, which is a fixed angle for each individual. This has quite a big range, but most often is between 50 and 55 degrees. And this does not change during a patient's lifetime. And another important thing is lumbar lordosis, which is usually measured from L1 to S1. And usually, if you have a balanced spine, the lumbar lordosis and the pelvic incidence should be similar, or 5 to 10 degrees away from each other. So when there's a big mismatch between the pelvic incidence and the lumbar lordosis, it comes to your mind that maybe there is an imbalance in the sagittal balance of this patient. Other things to measure are the sacral slope. So you draw a line, a horizontal line from the posterior corner of the sacrum, and measure that to the sacral end plate. And you also measure the pelvic tilt. So a vertical line straight up from the midpoint of the femoral head, and another line to the midpoint of the sacral end plate, and that angle is a pelvic tilt. So the pelvic incidence is a combination of the pelvic tilt and the sacral slope. pelvic tilt value is normally between 11 and 15 degrees, and it's a very important indicator of pelvic retroversion. So when you're having a pelvic tilt above 15 degrees, you know that the pelvis is compensating by retroversion for a abnormal shaped spine. And when you see these compensation measures, that's when you start thinking, perhaps I should think about reducing this spine rather than just fixing it in situ. So when the spine is imbalanced with, say, for example, Spondylolisthesis, the body compensates by pelvic retroversion, by knee flexion, ankle extension, reducing thoracic kyphosis, and also flexing the hip as well. So you'll see a patient walk in with an imbalanced spine, with knees flexed, hips flexed, and just trying to keep themselves upright. The advantage of reducing the Spondylolisthesis and fixing it is that you get a better restoration of sagittal balance. You get higher union rates and better foraminal decompression. And the potential disadvantages are increased risk of neurological injury, and all of the neurological injuries most often temporary. Another thing you may get asked about in your vivas or clinical stations is about what happens, what do you do with spondyloptosis. So you should probably just have an idea that there's such a thing as a Gaines procedure for spondyloptosis, where essentially you can see in this diagram where L5 is completely fallen off anteriorly from the sacrum. And in such a procedure, you enter anteriorly and you completely remove the L5 vertebral body, and then you reduce the L4 vertebral body onto the sacrum and fix it from posteriorly. So you go anteriorly as the first stage, and the second stage you go posteriorly and reduce L4 on the sacrum and fix it there. Okay, thank you.